Thank you for viewing the Cultural Considerations presentation presented by the InterTribal Council of Michigan's Health Education and Chronic Disease Department on February 14th, 2018. Today's presenters are Noel Pingatore, Department Director for the InterTribal Council of Michigan, Joshua Hudson, Program Manager for the InterTribal Council of Michigan, Cathy, Edgerly, Program Manager for the InterTribal Council of Michigan, and Raeanne Madison, Program Manager for the InterTribal Council of Michigan. Today, Noel Pingatore will introduce the presentation and offer an overview of both the InterTribal Council of Michigan and the Health Education and Chronic Disease Departments. Joshua Hudson will offer a presentation on tribal health systems, law, budget, and realities. Cathy Edgerly will discuss cultural competence and communication and speech. And Raeanne Madison will discuss trust issues, trauma-informed practices, respectful communication, and culture and language. And now at this time, we'll go ahead and throw it to Noel Pingatore to kick off our presentation today.
Good morning. I'm enjoying just sitting and visiting with all these familiar faces and friends, so I'll try to compose myself and get into presentation mode. But it's wonderful to see all your faces. And I was sharing with both Holly and Angela, we really appreciate the fact that you're giving us your time this morning to learn about the population that we serve. It really means a lot to us because I know how busy you all are, so thank you for your time and attention. Appreciate it. I think the title of our presentation is Working with American Indian Communities and Cultural Considerations. So again, we're really pleased that you're giving us your time and attention today to learn more about this really unique and culturally rich population of Native Americans here in Michigan. Thank you for that. I'm really happy to share and bring a lot of our staff that I get to work with. These are fabulous people, and I'm glad that you get to meet them. A lot of us are from the Department of Health Education and Chronic Disease, and we also have staff, Raeanne Madison and Michelle Schulte, that we kind of share and work together with in maternal and child health. And just like you all, we're learning the benefits of collaboration and integrating the work that we do to have a larger impact. And so we're really happy about that. We also have Chris Sands, and I want to specifically point her out. She's with us today because none of the work we do would ever happen without her. She's our administrative support staff, and she takes excellent care of us. And we wouldn't even be here today without her help in coordinating and arranging, and she really goes above and beyond. So I want you to know who she is. She's the backbone of the department. And I want to talk a little bit about the InterTribal Council of Michigan. So it was actually founded in 1966, and at that point, there were 3 or 4 tribes, and I'm not real definite on the 3 or the 4. And as time evolved and more tribes became federally recognized, that grew to 7, and now today we're up to 12, including American Indian Health and Family Services, which is an urban center in Detroit. You're probably familiar with that agency. So that's some of the growth that has happened. We're a tribal consortium. We're governed by the board of directors, which is made up of all the tribal chair people. So all 12 tribal chairs come together, they meet quarterly, they provide guidance and oversight to the InterTribal Council of Michigan. So we work for them. Just want to make that clear, and it's wonderful work. And similarly, like maternal child health and health education, a lot of our departments report to the tribal health directors, and they meet on a quarterly basis, and they actually are an association. So our role in working for them is really helping them to identify needs, develop programs, and find resources to implement programs and services at the tribal level. And we do that under the guidance of the tribal chairs and the health directors. I did want to talk a little bit about the various departments we have at InterTribal Council. So there's economic development, early childhood, behavioral health, environmental health, health education and chronic disease. We also, in our building, rent space to some other agencies, UpCap, and we have a veterans program that's also part of our, under under our umbrella, I guess. And I did want to talk too a little bit about I guess I'm going to frame it in the history of InterTribal Council of Michigan and try to give it some context. So when I was thinking about this, one of the things that came to my mind was under the 7 grandfathers' teachings, one of them is humility, and I'm constantly reminded of this teaching. So in my experience, working with tribes and tribal people, and some of the teachings that have been passed on to me, we might not talk a lot about our successes, or maybe how far we've come, but really stay humble and focus on what we need to do next and where we need to go. However, I want to frame this in terms of like the history of InterTribal Council of Michigan and some of the strengths that I have seen or experienced in my time there. So I think the first thing that comes to mind is when I started, we were closer to 7 tribes then, and tribes would have a very small amount of money from IHS under what's called 638, Public Law 638, which Josh is going to speak to you more about later, to provide some health education services. So that at that time, the tribes didn't have basically the infrastructure or capacity to everyone, or the funds to hire, say, health educators. That's an old term, right? For each tribe. So they pooled their money, and we would have 1 or 2 at ITC. And we would go out and spend days, maybe a week or so, at each of the tribal communities delivering those services for them. So as time went on and capacity and infrastructure grew, the tribes were able to, allocate more funds and provide their own health education services. So they took the money, the 638 money that would have been at ITC, back in their own budgets to support those services. So simultaneously, the InterTribal Council of Michigan grew as well in infrastructure and capacity, and began to address all of the essential services, all of the public health essential services, and really grew more in technical assistance, more in support, more in evaluation, rigorous community needs assessments. And so what I found really maybe a proud moment or to reflect on ITC is we actually lost money, but we gained staff, we gained programs, and we grew. So I think that speaks to sustainability. I think it speaks to the strength of the agency and its ability to adapt and change over time with the needs and resources as they come up. So I hope that makes sense. We also grew, I think I was taking time to reflect on this morning. So when I started in, let's just say 21 years ago, there were actually 2 FTEs under health education. There was 1 full FTE, and then a coworker and I split the other half. And now we're up to, just in health ed alone, I think we have 6 staff, but we also grew another department. The maternal child health department didn't exist at that time. So now they probably have 5 or 6 staff, if not more. And I can't speak to the other departments because I don't work in them, but I think we've seen them grow as well. So the fact that we're able to grow and expand and under less money, we're totally grant funded, I think speaks to the dedication and the skills and the leadership of the InterTribal Council of Michigan. I'm very proud of that. Thank you for listening. The other point I was going to make was more toward the passion of the people that work for ITCM and again their dedication. We used to be housed in 3 separate locations in Sault Ste. Marie. Everybody knows where that is. Should I do that? Way up here. The health services division was actually above the Sioux Tribe Commodity Food Warehouse. So you're familiar with Commodity Food Warehouse. That's where people go to get their foods and their resources. So because it was a food warehouse, we had mice. And I remember being at my desk and typing away, and the mice would run over my feet. Oh, yeah. And then it was fun times because the staff, in order to address the issue, would bring in like pet ferrets and all kinds of things. So those are unique working conditions, right? Like not everybody's up for that, but the health services staff certainly was. And then the administration staff was downtown in Sault Ste. Marie in a very old building that didn't meet any fire codes. And then they also acquired a very old house and remodeled didn't remodel it, but made the house work for office. So this is when we're trying to grow. So I just think, kind of giving you the context of where we've been and how far we've come speaks to some strengths and unique dedication and passion for the work that we do. So thanks for listening to that. There's the map. I wanted to point out where all of the tribes are located and kind of give a little perception on their service areas. So we do a lot of traveling. We try to get to each of the tribes and do site visits. Site visits are so important. We learn so much more when we sit down with the people we're working with and actually listen and hear their story. And it's much more than we can ever get in an email or even a phone call. So we are on the road a lot. Any questions about the locations of any of the tribes? I'd like to point out that they go from the northern Wisconsin border down to the border of Indiana. And Pokagon actually has members into the state of Indiana. And Glenn Copeland's not here today. I would want to sing his praises, but too hard.
No, do you mind just, I can't see
Oh.
the text from here, do you mind just reading
Yeah.
off the words?
Absolutely. So in Sault Ste. Marie, there's the Sault Ste. Marie tribe of Chippewa Indians. And about 20-25 miles west is the Bay Mills Indian community. The InterTribal Council of Michigan is also in Sault Ste. Marie. We are literally 2 doors down from the Sioux Tribe Health Center, which that just happened by luck. It's kind of interesting. The Keweenaw Indian community over in Baraga. Lac View Desert Band of Lake Superior Chippewa Indians, they're right on the border of Wisconsin. The Hannahville Indian community, kind of north of Escanaba. And then we get to Little Traverse Bay bands near Petoskey, Peshabi town. The Grand Traverse Band of Ottawa and Chippewa Indians out here on the Leelanau Peninsula, beautiful, beautiful place there. The Little River Band in Manistee. I hope I say this right, the Matchi-Benashiwash Band of Potawatomi, we call them Gun Lake. And the Pokagon Band up here in Potawatomi down here on the Indiana border. There's also the Nottawasepi here on Band of Potawatomi, and they have 2 locations. They have kind of in Grand Rapids and one down lower Michigan. American Indian Health and Family Services is right here in Detroit. And the Saginaw Chippewa Indian tribe is just north of here, 45 minutes. Mount Pleasant. Did I miss any?
No, thank you.
Wonderful, sure. So with that brief introduction, again, thank you, Miigwech, thank you in Ojibwe for your time and attention today. It really means a lot that you are interested in learning more. I did want to speak a little bit about, before we get into introductions, when I'm talking about the growth that ITC has experienced. I want to acknowledge the fact that we've done that with wonderful, successful partnerships, including MDHHS, Michigan Public Health Institute, other tribes and tribal organizations, because we couldn't grow if we didn't work together.
So I'm Josh Hudson. I'm a program manager for the National Native Network, which is at the InterTribal Council of Michigan. We're one of the 8 federally funded networks to focus on tobacco and cancer disparities for the priority populations. And we're right in your backyard. So sovereignty. I don't know about mainstream communities, but in Indian country, sovereignty is talked about all the time. So what is sovereignty and what does it look like? So sovereignty is the recognition of power and autonomy. It's an inherent right of self-governance. So when the United States signed the Declaration of Independence, they were declaring their own autonomy, which is the basis of sovereignty. So sovereignty at the federal, state, and local, they're all pieces of a whole that started in 1789 with the signing of our Constitution. And sovereignty of tribes is pre-contact autonomy. So many tribes have entered into treaties with the colonizing agents. So if that was the British colonies or the United States of America. And why does it matter? Sovereignty is the cornerstone of governmental legal frameworks. Tribes have judicial establishment of their inherent sovereignty, which I'll talk about here in just a couple. And it promotes the nation-to-nation relationship, which currently is seen as the federal consultation, and then there's the federal trust responsibility, which I'll get into. So I gave handouts, which you have. So it's 2 pages front and back. I thought this was really cool. I included a URL at the bottom. It's from the Kaiser Family Foundation. It's kind of a look at federal Indian policy, and so with each swirl, I've listed over there on the left, and then there's decisions, laws covered along the way, and then I wrote some in blue ink because it wasn't like fully comprehensive and it wasn't covering everything I wanted to cover. And then on the other page, there's it written in list form if that's easier for you, if you're not visual, and then some definitions in the back. So, but just kind of going over it, conquest was the mindset for the initial founding and expansion of the English colonies and the United States. Part of that is manifest destiny. God placed us here, so we will move west. You know, so that's things that, and that's just things to think about in terms of where we are right now is Indian land, and all of the United States is Indian land, and all of Canada, and all of Central and South America. Like this is all indigenous land. It's just been either taken or sold off. So going down the list of relations, it gets better as we go on, I promise. There was the era of treaties, which is really important, which set up the federal trust responsibility, you know, which is a formal agreement. So treaties are formal agreements between two sovereign nations. Both the colonial settlers and the United States governments use treaties with Native people to solemnize agreements, usually related to land and territorial usage. The next bullet on the list is assimilation, which is a process in which a person or group of people adopt the culture, language, and customs of another group of people. Assimilation was a key strategy for the U.S. government, which manifested in government-run boarding schools, the forced removal and adoption of children, and intensive religious indoctrination. Next on the list is reorganization. It's a time period in which the U.S. government created a process in which tribes could organize governmental structures that represented, like, it resembled the Western form of governance in order to obtain resources and funding for programs to benefit Native people. So that's how we have, like, tribes today, is under the reorganization. The next part is termination. There was a period of time where our federal government actually terminated tribes because they were seen as self-sufficient. So they did that to extinguish any responsibility that was there. So in the treaties that were signed, if they were going to provide food rations or they were going to provide education, they no longer would have to do that. And then self-determination, which is where we are today. It's the idea that they know how to run themselves best and we'll work with them to achieve the mutual goals. And so when we talk about Indian Affairs, which is here on the right, the Bureau of Indian Affairs is currently in the Interior Department, but it originated in the War Department. So I always frame it as we went from being an enemy to a manageable resource, because the Department of the Interior manages land, animals, and Indians. So, things to think about. So this is really like legal heavy. That's why I gave you handouts, because it's not what the average person's spare reading is like. So the legal standing and key legislation. So this is some of the early precedent. The Marshall Trilogy. Does anyone know who our first Supreme Court Chief Justice was? His name was John Marshall. He was also the longest serving Chief Justice. So he oversaw the court at its inception, and there were 3 major cases that set up federal Indian policy as it is today. So Johnson versus McIntosh, which was in 1823, it established that only U.S. government can purchase native lands. So Johnson and McIntosh, one had purchased their land title from the government, and one had purchased it from the Passamaquoddy tribe. And he ruled that only the title from the U.S. government was valid because Native people can't sell it off. Cherokee Nation versus Georgia, it established the domestic dependent nation, which created a guardian and ward relationship between tribes and the U.S. government. And then the third was Worcester versus Georgia. Worcester was actually a missionary, a religious missionary, and he was trying to help the Cherokee people because Georgia was pushing them out because there were resources that they needed. So they were kicking the Cherokee out. So Worcester was actually working on their behalf. But this decision established the relationship structure of the federal tribal relations, which, you know, is interesting. So United States versus Kagama, it established in the Supreme Court decision that congressional acts could be used to work with tribes instead of treaties. And it also stated that tribes owe no allegiance to states, that, you know, they aren't required to submit anything to them. In 1921, there was the Snyder Act, which created funding for American Indian healthcare. In 1934, there was the Indian Reorganization Act, which created the process for tribes to form distinct governments, but it had to be in the image of the United States. Which, side note, which is interesting because the United States form of governance is actually partially based on the Haudenosaunee people, which people know as the Iroquois. So the United States modeled after Indians, and then Indians had to model after the United States, which is interesting. But so we call it the IRA. There were 3 tribes that formed under the IRA immediately, starting in 1934. It was the Saginaw Chippewa tribe, Bay Mills Indian Community, and Keweenaw Bay Indian Community. And then the last one on this slide, the Indian Citizenship Act of 1924. It granted citizenship for taxation purposes to Native people. They wanted to make sure that we were citizens so that they could tax us for any income that we would be getting. Things to think about. So present day, IHS, the Indian Health Service, was established in 1955. It was a new department under the Public Health Service. And then the Indian Self-Determination and Education Assistance Act of 1975 allows for 638 contracting. And we call it 638 because it's Public Law 93, so that was the session of Congress, and then 638, that was the number that happened. So when you hear 638, it's like a verb now and a noun, like, oh, we're 638ing right now. Like, you know, tribes will say that. So, you know, that's things to think about. So it created space for 638 to contract for tribes to administer federal programs and be reimbursed. So all of our tribal clinics in Michigan are 638 clinics. IHS doesn't administer any clinic, all the tribes do here in Michigan. The Indian Healthcare Improvement Act first was passed in 1976, but it was permanently reauthorized in 2010. It ensures access to quality health programs, aid in developing capacity and infrastructure, and advocacy efforts. And it was permanently authorized as part of the Affordable Care Act, which is Obamacare. Which I'm sure most of you know, but if you didn't, now you know. And so currently we have consultation, which was like 1998 to now. Under the Clinton administration, there was federal guidance given under an executive order that when you're dealing with tribes, you have to do nation to nation. So it's not just some, you know, some random in the department working with somebody at the tribe, because that's not respecting them as a governmental body. So that's why consultation is so important. So trust responsibility. So the federal government, as a treaty signatory, agreeing to certain trust responsibilities. The scope varies, but large examples include healthcare, education, and land management. And why should the government provide these services for tribes? As the treaties stipulate, these services must be provided in exchange for the land cessation. So this is how I explain it to people, because they're just like, well, Indians are getting all these things. Why? They don't deserve it. Tribes paid in advance for all of the rights and services, and they should continue to receive them for as long as the United States uses the land and resources. So if the United States doesn't want to honor the agreements, they can always give the land back. You know, so it's this idea, I can't go to the dealership and get a car and then not pay back without consequence, right? Like, that's just the exchange. So, medical expenses. So the Indian Health Service is a federal agency, and here's federal healthcare expenditures per capita. They're not all from the same year, but when we look at the far left, Medicare was 2013 per beneficiary. They spent $11,910. The second one in is the national average per capita of, like, the national average of expenses people pay. $8,097. That was for 2014. The Veterans Affairs in 2014 paid per patient $7,036. Medicaid in 2010 paid per enrollee $5,563. And then here on the right we have IHS, which spent a total of actual spending in 2014, $3,606 per user. Of that, $3,107 were for medical expenses and $499 were other, which refers to IHS facility expenditures. So that's being aggregated over the population, the expenses for the facilities. So IHS is deeply underfunded. It has never been fully funded. And it operates at 50 to 60% less funding than every other federal program that's responsible for healthcare delivery. I didn't include the Bureau for Prisons, because I didn't find that number, but I know that they pay more. And I think the last time they published a number was like 2005, because they aren't publishing that information anymore because it's being used as ammo. So this is just like things to look at, like the stark realities of like Medicare beneficiaries versus IHS. So Indian Health Service is actually one of the largest like healthcare providers from the federal government. And so they're separated into regional offices. And so those regional offices are broken up into larger, like when you see data, it's typically aggregated in Alaska, Pacific Coast, Southwest, Northern Plains, Southern Plains, and East. So Michigan's part of the Bemidji area office, which is in the dark blue, but we're part of the Northern Plains region. So changing directions a little bit, we're going to talk about tribal governance structures. So tribes are sovereign entities. They answer to their people and sometimes the federal government, but only in specific situations. All tribes are unique in structure, organizational flow, and processes. Tribes are typically centralized small governments that require multiple levels of approval. And a good way to think about it is like a city or a municipality. That's what like our tribes are, because there's police, there's fire, they're providing healthcare, which most cities don't, but like that's the unique part about being in a tribe. But you know, trash, you know, like all of these like concerns the tribe has to worry about for its people. But tribes typically don't have taxation revenues, and so they have casinos. But when you look at the structure of like casino funding, it pretty much reinvests itself back into the casino. So that's paying for employees, that's paying for utilities, that's paying for all the various items that come with operating a casino. Most businesses only earn as much to keep going, and then with a small profit margin. So with a little bit of profit margin, they're running a whole city, basically. Think of it that way. So executive leadership typically oversees health programs, but things to note are there's limited knowledge and awareness to the nuances in federal healthcare delivery, and that there's a vast breadth and depth of responsibility, and there's just not enough time to fully immerse themselves in healthcare needs. Like for me, I'm from Bay Mills Indian community. Our executive council is 4 members who all work full-time jobs, and then you know, like basically they get paid a stipend, but you know, they have like 4 meetings a month, like once a week. That's just not enough time for them to get fully immersed in healthcare needs when they're doing everything else too. And it's really important to note that signature authority placement varies with each tribe. Sometimes only the president of the tribe can sign formal contracts. Sometimes if it's a health program, the health director can, and sometimes it can be the program manager. Just depends on how everything is set up with the tribe. But it's also important to note that tribes are not beholden to outside influences, including the state and the InterTribal Council of Michigan. They will make their own decisions in whatever way they see fit. We can try and inform them the best we can, but we can't make them make any kind of choice. So tribal health programs, 638. So that's IHS programming in Michigan. Tribes are administering federal programs and being reimbursed. It allows for self-determination of how programs are administered, even if they're deeply underfunded. It's worth noting late repayment and or underpayment is not uncommon. Multiple class action lawsuits for contract support costs have been successful, so tribes have been paid back retroactively. You know, so imagine if, you know, your, like the cancer section got funded every 3 months. Like, would you, like sustainably, could you still operate all of your programs? That's like what tribes have to do. Budgets are constrained and have a cap, and that any over expense is the tribe's responsibility. So, you know, again, it's like balancing the health versus like, are we gonna pay the electricity? Are we gonna, you know, help pay for elders programming? Things like that. You know, so moving down to priorities, our staff are overworked, overburdened. They're working to fulfill multiple duties and roles, and that there's a lack of resources for multiple full-time employees in conjunction with chronic understaffing. And that the focus is primarily on treatment, and there's not enough time or resources for preventative efforts. And so now I'll throw it back over to Raeanne and Cathy. So thank you.
Thank you, Josh. Happy Valentine's Day, everyone. I noticed some red in the room. Someone had red boots. Who had the red boots? Without even seeing. Very cute, very cute. All right, so I'd like to add on to a little bit to what Josh had to say about tribal health systems on the topic of cultural competence. And cultural competence is defined as the ability to effectively communicate and understand the differences between different cultures. And there are several key elements, and I've listed 4, starting with being aware of accepting and valuing someone else's culture and those differences. And in order to do that, it's helpful to understand your own culture and values. And then you use that information to understand the range of dynamics that take place with the interaction between different cultures. So I'll share a little story. I'm a non-native, but I've worked in the tribal community and lived in the tribal community for a very long time. And it is tribal practice to honor the elders. Raeanne mentioned the importance of respecting tribal elders at meals, and we honor them by allowing them to eat first. So I was at a meeting about 2 years ago where food was served, and the host of the meeting used a microphone and announced that it was time to eat, and requested that the elders stand in line at the buffet first. So several people stood up and got in line, and I was just tidying my papers and just kind of waiting. And the host wanted more people to stand up. They weren't moving fast enough, so he started calling them out by name. And the next thing I know, I heard my name called. And I was like, me? I'm an elder. So I had to laugh, but when I looked around the room, the population, it was a lot of young people. So I graciously took my place in line, knowing that it came from a place of respect. And I think that's just a really wonderful practice. And then it's not only important to have an understanding of the knowledge of a different culture, but to continue to increase your knowledge so that you may effectively work with not only individuals, but families and communities in the work that we do. And I know I personally learn all the time. I'm still learning. And then another context of cultural effectiveness is understanding communication. So the InterTribal Council works with a lot of partners, state and federal partners. And one of the projects that we worked on at least 2 times is a Native American specific behavioral risk factor survey known as the BRFIS. I'm sure you're all familiar with that. When we worked with the surveyors at Michigan State University and also the State Office of Minority Health, we requested that we would be allowed to provide a cultural training to the student surveyors before they made those phone calls to the Native American community. And this is one of the slides that we included in that training, and I just thought I'd share that with you. One of the terms that is familiar in the Native American world is called walking on words. And this just means speaking at the same time as someone else, or interrupting, or trying to finish their sentence. And this is disrespectful. Some American Indians speak at a slower pace, and I know I tend to speak rather quickly, so sometimes I have to slow myself down so that I'm understandable. There may be a long pause in someone's response. So if you're speaking to them and they're answering your question and there's a pause, you may want to fill in that pause or answer the question for them. And if you do this, this is rude, once again walking on words, and it's best to apologize and let them finish their story or their response. I wanted to share with you the Tribal BRFIS Toolkit. We have copies of those if you're interested in seeing them. And it gives a little background on our work and doing the survey in a good way. All right, next Raeanne's gonna come back up and she has a little more information about communication, and she's also gonna speak to us about trust issues.
So a lot of communities of color, American Indians are certainly included in that, have a fear or mistrust of authority figures, including healthcare providers, public health professionals, law enforcement agencies. And it's because within different time frames in our history, we've really faced a lot of abuses and times when our communities have been taken advantage of by authority figures, and that sort of still lingers in the community. So I wanted to give a few examples of that to just give a little illumination as to why that is. Joshua spoke briefly earlier about the boarding school era, and it's interesting because we call it an era, but it's still such a long time, a long period of time when Native American children were often forcibly removed from their families, some as early as infancy, to be taken out of the community, to be placed in a school that was often run by the military or by the church. And the whole purpose of the schools was one, to assimilate Native American children away from their original, their culture of origin, to get them to learn English, to have them be prepared to go out into the workforce and be a part of white culture. That was a federally sponsored program. How many of you were alive in 1983? You were alive when the last boarding school was open and operating in the state of Michigan, in the city of Harbor Springs, which is up in the northern Britain. So that legacy of removal of our children, and to us our children are very sacred. We say they're our ancestors that came to us, that every child is a gift. So to have them taken away was very traumatizing. A lot of the adults who didn't die in boarding school, because a lot of children did pass away from the stress or from hunger or from running away, the ones who came back tended to have a lot of suffering, that they brought back to their communities. So that's the context we're working in today. It's a really interesting one when you think about that it was just 30 years ago. Another example has to do with the Native American Graves Repatriation Protection Act, which was enacted in the 1990s. So up until the 1990s, universities, including Central Michigan University, MSU, the University of Michigan, it was totally legal for them to go into tribal lands, dig up our graves, steal the remains, take the funerary items and sacred items that were buried with them, which has an immense amount of spiritual and cultural significance to our communities, and take them and place them in museums and do testing on the DNA, certainly without the permission of the leaders of that community. And that was just 20 years ago, and so we're kind of in this time frame now where a lot of, you probably see it in the news, a lot of communities are able to fight universities to get their remains back, and you might have heard of some of those repatriation efforts, where we have ceremonies to rebury the remains and to honor them in the way that should have been done, back when they were first removed. So that's another reason why people are just scared, because they remember those things happening. There's also been instances where researchers have, taken data from the community, and it doesn't seem as insidious as digging up someone's bones, but that's still information and knowledge that should remain with the community. There's been books and papers published on data that came from Native Americans, and permission was never granted to the researchers to further their own career by using our information. So that becomes really important in our communities. When we're working with them, we always have an understanding at the very beginning of a project that the tribe owns the data. The data passes through us. Oftentimes we do projects where the numbers are so small, and we at the ITC can never publish it because we have given that data back to the community that it came from. It's really for them to use to their own benefit. The U.S. Public Health Service, again, well into the 1980s, had a program that offered sterilization, permanent sterilization to women of color, Black, Native American, Puerto Rican, Mexican. Around 25% of our women were sterilized. They would go in for a C-section, they would come out, they would never have another child, and it was not until, maybe 10, 20 years ago we fully understood the scope of the amount of sterilization that happened against our will. So when we are public health professionals, we have to know that history. We have to understand that communities remember that. They hold on to that. You know, they have this mistrust, and it's for those reasons, very important reasons. But it's also a good opportunity for us because we can be the change. We can help to undo some of that trauma and really model respect for them and say that it's a different time. We don't do that now. We want to really do things the way that they tell us and the way that our communities ask us to do. So there's a way that you can put this all into practice, and it is a practice. So as Cathy mentioned, we're always learning and we're always integrating the new knowledge that we have, and we want to do better as often as we can. So we can model respect. You know, we can be the public health professionals who do things the best way we can. Staying open, genuine, and honest is so important, and really being able to field questions and value questions. Understand that when you work with tribes, there's going to be a lot of why. You know, why are we doing this project? What's the need it's fulfilling in our community? Who owns the data? Why does this benefit us? You know, what are the risks involved in participation? So it's good to just be comfortable doing that and answering those questions and finding out the answer. If you don't know, that's fine too. Avoiding judgment and focusing on positive communication is so important. We always try to use a strengths-based approach. You know, our people survived so many terrible things, and it's because we had a lot of great things in place. You know, what is it that propelled us through all of those traumatic times and those time periods in our past? We can really draw upon those in the work that we do, and we can really use those strengths to our advantage in the work that we do today. So some more respectful communication practices to be aware of. Remember that there's so much diversity within our tribal communities, and there's a lot of different life experiences and significant things within each individual and within each community that we may never know. You know, we couldn't possibly know the story of every community, and it's not our job to. Our job is just to really stay open and to be aware and observant. So just some diverse aspects of our community. Around 60% of American Indians don't live on a reservation. They actually live off the reservation and most often in a city. So I always point out to folks that there's 50,000 American Indians in the Detroit area alone. So if you work in Detroit communities, most likely you're going to be working for Native Americans. And then a lot of our reservations, they're really in rural areas that are very far isolated from the nearest city. I always tell people, you know, in our home community, to get prenatal care, you have to drive 30 miles in one direction or 90 miles in the other. So it's a significant burden for our families. And we all know what the winter's like up north. You know, you might have the power out. There's literally roads that close all the time because of the danger of driving, you know, in deer and those types of things. So just gives a little clue. And yes, there are still communities that don't have internet connection or phone, you know, so these are the types of things that we have to think about when we do work with them. Traditional versus non-traditional. This goes on to the next one, the stereotypical Hollywood American Indian. A lot of folks have this vision of what it means to be a Native person or what it means to be American Indian, and it often comes from the representation that we see in our history books as children and in the media. And you know, our people are very diverse. There's folks who are come from the Judeo-Christian tradition. That's where their family is rooted. There's folks who are more rooted in the traditional teachings, and there's folks who do both. You know, there's people who draw upon the different customs depending on their family background. So we can't never assume, you know, that people are a certain way depending on, you know, their family history. There might be a lot of differences there that we can be respectful. So this is really important if you do work over the phone or if you work with tribes and you do face-to-face meetings. Sometimes people in our community aren't accustomed to answering direct questions. And this became really important when we're talking about things like the BRFIS or the PRAMs, you know, the Pregnancy Risk and Assessment Monitoring, which is going on currently. So we always tell people that when you're asking someone about their health history or their family history, you have to really give them time, and you have to be really respectful when you do that, because as Cathy mentioned, or Noel, I'm sorry, at the beginning talked about the importance of humility. Humility and modesty is something that we're raised with as Native children. We're taught that, you know, we are to sit and observe what the elders are doing. And oftentimes it's to sit with your eyes down and you don't make eye contact. For some Indian people, it's rude to just stare them in the face and ask them a direct question. So sometimes we have to be comfortable with those differences and just observe the group you're working with. What are they doing? You know, you see a lot of younger folks who are sitting like this. That's because they were raised in that way too. And it's no disrespect to you, it's just the custom that they come from. We're also, you know, going back to the trust issues, we keep our stuff private because we don't want everyone knowing our business. So it's really an honor for us to even get in the door and to get some of these projects approved. You know, it takes a lot of trust and respect to get the door open. Respect for elders is so important, and it can't be emphasized enough. Oftentimes, young folks will not answer a question because we're giving the elders time to formulate a response, and we'd rather hear from the elders first. So oftentimes if you have some request or you know, if someone's going to open a meeting up with a prayer, that's very common. You might see them passing a small cloth that holds tobacco inside, or sometimes it's even just loose tobacco. It's not in a cloth, and they'll just put it in your hand. So you might see that. It's a protocol that's very deeply rooted in our traditional culture. It's a sign of respect, and it's also a gift. So we recognize that there's always an exchange. You know, when you have a request, I'm asking you for something, so it's my responsibility to also give you something back, because it's part of that reciprocity. And so you may in your career have an opportunity to pass tobacco to somebody, or you may yourself receive it. It's not uncommon to come to a gathering and to see tobacco on the table, and that means you're welcome to use it as well. So despite all the doom and gloom, I wanted to end on a good note. I always want people to know that our people are so fun and so awesome to work with, and it's really an honor for us to do the work that we get to do. Humor is so important to our people. You know, you'll come into a meeting and we gotta talk about the HIV epidemic or the cancer burden or infant mortality, but we still have a light way of doing things. And humor, teasing, laughter, joking is very common. People who have worked with our communities, researchers, surveyors, program staff from MDHHS have said it's really such a joy. We've had people tell us that this is their favorite community to work with because of that fun nature, because of the humor and the teasing that goes on. So it's just good to keep that in mind. You can never tell who's Native American just by looking at them. You know, we have such a diversity in our community of skin tone, skin color, ethnicity, cultural backgrounds. You know, we're very diverse. We have a lot of history of intermarriage between many groups of people. You know, the history of our relationship to African Americans didn't start with slavery. You know, we had a friendly relationship, you know, and same with people from Mexico or people from Puerto Rico. It's not uncommon to find families who have a lot of that culture all in the same family. And so I just always put this in there because I like to say, yep, everyone in this picture is Native American. You know, you couldn't assume just by looking at them that they are or aren't Native American.
Thank you for taking the time today to view our Cultural Considerations webinar. For more information and resources from the InterTribal Council of Michigan, please visit our website at www.itcmi.org.